for the Zoom call today. And welcome everybody. My name is Daniel Stein and one of the co-founders of Stewards and the National Interoperability Collaborative. And I want to welcome everybody to today's session. It's been a little while since we've done these kind of webinars again. But I'm glad that we're back on the saddle, so to speak here. Can everybody, is my voice okay coming through here? Everybody here okay? Mike, is my voice coming through okay?
It's good. It's clear. Yeah, not like crystal clear, but it's good.
It's okay enough.
Okay, great, thanks. So today, today's meeting is really focused in on the proof of concept that we have been working on for years, called Project Unify, and it is an opportunity to update folks who have been participating in the work for a while, to hear what the status is of it. And I might just recall or remind you that this is part of the Let's Get Technical group. Many people have been participating over the last year on these calls, which are intended to go a little deeper into some of the technical components of the efforts that we have been leading and participating in over the past year or so. And so we have an hour and a half ahead of us today to dive into this topic and update you guys on where things are at. And so with that, let me just, not that I need to really provide too much information on the housekeeping, except since everybody's been on too many calls, I'm sure. The main thing here is we are recording. We do want to invite questions and comments throughout. So one good way to do that is to do it through chat as usual, or raise your hand using some of the icons, or just break into the audio if you're compelled to do that. And this, as I said, will be recorded and we'll be posting it to the National Interoperability Collaborative Hub, where you can find, gosh, maybe about 50 other videos we've done from the year. And so feel free to binge watch at any point in time, any of them. There's a lot of really good presentations. In fact, there are earlier presentations about the proof of concept as well. If you haven't signed up yet, please go ahead and do that. And then, as I said, we will be posting all of this material on the hub as we go forward. And so with that, let me just dive into today's agenda a bit more. And so we have a couple of things. I'm going to give a little bit of an overview of the NIC and where we're at on that. And in particular, this new initiative called the National Action Agenda. I have spoken about this in the past. Many of you may be familiar with it. Some of you are actually participating in it, and we welcome you to join these activities as I described them. And then we're going to focus the bulk of the time today on Project Unify, the user story associated with it, and actually do a live demo, the first live demo of it. And then throughout we'll have discussion and conversation, as I said. And so we have some other presenters with us today, folks you may know, and we'll introduce them as we go forward here. So just a few starting comments I want to make about the National Interoperability Collaborative for folks that may be new to it. This is an initiative that we started with support from the Kresge Foundation about 3.5 years ago. And the intention of this was to create literally a community of networks that would try to focus on creating more collaboration both within and across the multiple domains and disciplines that are contributing to health and well-being, safety. And that, as I said, both goes within and across multiple domains. We focused in on 6 domains in particular. We kind of organized the world in terms of human services, writ large, public health, education, public safety, emergency medical response, and then healthcare and IT, healthcare IT associated with that. And we think about those domains as covering a lot of the territory that are front and center for everybody or anybody who's involved with the health and well-being world, especially during times of crisis, or to provide their contribution to overall solution. And so that's been a part of the foundation of the work we've done and are continuing to do. And part of the NIC is to bring together folks from these various communities to provide a location and a virtual watering hole for people to hear different ideas, begin to interact with more folks, and to begin that cross-pollinization that's so important to social determinants work, or value-based care, or whole person care, or whatever you might, or however you might want to think about it. And so we're excited to be able to continue that work. And the proof of concept is really it nests within the National Interoperability Collaborative. About this time last year, some folks came forward and said, this is really interesting and useful information, but what are we going to do about it? How are we going to use this stuff in some tangible, actionable way? And that really spawned the development of the proof of concept. And so there's been a group of folks, many of whom are on the phone today, who have been contributing to, in many ways, a collaborative, open API, open standards, and as much open source possible to develop a proof of concept that you will be seeing a little bit more about today. And we invite you to participate in that, learn more about it. But I want to spend just a moment now talking a little bit at a slightly macro level, which is the national action agenda to advance upstream social determinants and equity. So this is a very ambitious initiative that we started to think about at the very beginning of this year. We at Stewards of Change hold pretty much an annual symposium, and that symposium has been going on for about 14 years. And so we were planning that event in collaboration with the Stanford Center for Population Health Sciences this year. And then all of a sudden COVID came along, and we decided, well, maybe we need to adjust our thinking a bit more about how and what value it would be to bring together a group of thought leaders to think about some of these really hard interoperability problems. And we realized that the sort of the approach we were taking was not perfectly relevant. And what we needed to do is, certainly as February and March rolled on, all of us were beginning to adjust to that. We realized that maybe there was an alternative opportunity for us here, which was to recognize the incredible impact that the pandemic was having on all of our lives, and that we actually had the opportunity to potentially focus in on that and identify what would be possible to go do come the beginning of 2021. As opposed to sort of setting a goal, we figured we better think about where the proverbial puck is going and what can we do as a collaboration to advance the work in this unprecedented time that we're living in. And so that really was the foundation of this work around the National Interoperability Collaborative, and within that the NAA, as we refer to it. And our goal here is really to build a roadmap to help guide the design and development, and importantly, the implementation of, these are very carefully chosen words, system level cross-domain interoperability efforts to really advance social determinants. And that is a bold, ambitious, frankly, a little scary proposition, but if not now, then when? And can we do this in a way that would be supportive of jurisdictions across the country that are attempting to do similar work? So as opposed to allowing or forcing everybody to sort of start with the same blank page, we proposed and have been working towards creating this collaborative roadmap to guide the design and development of what would be systematic level change that would really affect the ability to prevent and intervene early in cases across the country. So that is the basis of the NAA, and within that, we have set some particular goals. And I'm going through this because what's important about this is that the proof of concept is firmly embedded in the NAA. The proof of concept and the work that's been going on and is continuing to accelerate now is very much about the implementation. There are plenty of studies, there are lots of blue ribbon panels, there are amazing things that have come out that really set a direction and identify the strategies. But we believe that there is truly an opportunity to go do or go implement. And the proof of concept is embedded in this idea. And that's why we're so excited about it. And that's why we want to share that today, because it's not just a proof of concept, but it's embedded in jurisdictions across the country. So the initiative is to identify and prioritize structural system level changes to improve upstream social determinants and health equity. And that's a place where we focus in on, which is focusing on the systemic changes, the root causes, including racial justice and socioeconomic disparities, to serve people who are really underserved and underserved populations. So many of whom are, so many more people are in that situation these days. How we want to do that is, and where we want to do that, as I said, on the prevention and upstream perspective. How do we dramatically improve responsible information sharing and interoperability? Fundamentally, this comes down to sharing of information, the right information to the right people at the right time with the right protections and the right access. That will bring the concepts down to implementation and will also point to those structural changes that need to be made. And then finally, what we intend to accomplish and what we're on the path to do is to identify and begin to implement a few, I'm talking 3, 4, 5, maybe max, achievable recommendations, things we can go do in specific locations that cut across domains starting in 2021 that we can show demonstrable progress. And that is really the differentiating goal from the National Action Agenda, from I think anything out there right now. It is to actually go do some things that will actually affect upstream and preventive activity and preventive opportunities. And that's in many ways really the goal. So it's ambitious, it's big, and we have the opportunity today to dive into the pieces behind that, as I said, which is really the integrated approach to supporting data sharing and information sharing. And so with that, I want to pivot now to actually diving into the pieces of that. And I'm going to ask Dr. McCoy from New Jersey to step in and describe a little bit more about what we're doing and how we're doing it. And I will drive the slides, Christine. So welcome to you. And here we go. I'll set up the first slide here.
Great. Thank you, Daniel. And good afternoon, everybody. For those of you who I have not spoken with before, I'm Christine McCoy. I am a family physician and I chair an organization called the Children and Family Health Institute in central New Jersey. And we are one of the co-leads in a 7-year cooperative agreement awarded by the Centers for Medicare and Medicaid Innovation. It was awarded to 8 different entities around the country, 7 different states, so 7 different Medicaid systems, since this is coming out of CMMI, and then 8 different other sort of partner organizations. And with the big picture goal, as you can tell from the title, of integrating care for kids in order as the major goal to prevent these children from being placed outside of their homes. And so this is a project coming out of healthcare that is looking to affect the lives of these children in a very broad social way so that they have the stability in their lives to stay at home, regardless of what that issue might be. I mean, they may have complex medical issues that sometimes require them to live in a nursing home, for example, or they may be placed outside of the home because of a variety of social issues that get them into the foster care system. They may have psychiatric issues that require long-term psychiatric placement. And so they may get in trouble with the law and end up in juvenile detention. And so not all of these outcomes that we are being asked to start from the position of a healthcare system are health outcomes. But there's this recognition that by working together across sectors, that healthcare is a touch point for kids, that is just that, like schools, is a very, very important place where we can access kids and start to make a difference, but that we can't do it alone. So, we had submitted an application for this process when I connected with Stewards of Change and the NIC project. And Daniel and I started this conversation about, well, if you get this award, wouldn't it be really great if your project could become our proof of concept, which was already being worked on. And in fact, this beautiful wheel that you have in front of you had been created, but it got a few tweaks in order to really have it represent the domains that were written in by CMMI into the Integrated Care for Kids project. So again, 8 different communities around the country, 2 in Illinois, North Carolina, New York, Connecticut, and who am I forgetting? Ohio. I always forget Ohio. Oh, and Oregon. Ohio and Oregon. So very, very different places, some rural, some urban, some suburban like mine, that are working to try to scale this work that the NIC had been talking about, and to apply it to the lives of children and young families over a 5-year period that begins at the beginning of 2022. So we have a little bit more planning time, which is great. And that's how the National Action Agenda and the work of Project Unify that you're going to see later this afternoon, really fits very well into our timeline to make this a reality that we can put into action here in Central New Jersey, but also our other partners around the country as well. So as you can see from this graphic here, we have the different domains. We have our child and their family and their community here in the middle. And then they're surrounded by the people that they interact with one-on-one. Hopefully not a probation officer, but it might be. Case managers from different sectors, case coordinators, and of course, the medical care team coming from each one of these jurisdictions. So this really just sort of shows how it all fits together and comes down, and yet right now operates in silos, where it's very, very challenging for people, at least they think it's challenging, to share information. They're not necessarily rewarded for sharing information, and they get a little scared of the lawyers, and they feel like maybe they can't share information from one wedge of this to another wedge. And so that's really what we're going about addressing, both from a technical and a legal standpoint. So next slide. Or next part of the slide. So to help make this real, and for those of you who are part of the National Action Agenda, you have seen this many, many times. We find it sometimes helpful to think of it in terms of a potential family that might come into our project. And so in our project, our project is affecting all Medicaid kids. Now, kids is defined as up through age 20 in 2 counties in New Jersey. And the typical entry point for any of these kids will be when they come for a well child check. But there are other entry points as well. If their school or their daycare or their Boys and Girls Club or anyone else is concerned about this child, this can be an entry point for them as well. So to think about a type of family that we might become involved with, we have the Thompson family here in front of you. And what's really nice about this scenario is this is a 3-generation model. And integrated care for kids requires us to at least have a 2-generational approach, because we recognize obviously that kiddos are not living by themselves and independent of their parental or guardian situation. So the Thompson family consists of mom and dad, Sarah and John, and their 2 children, Madison and Jameson, and Sarah's mother, Ruth. And the brief story of this family is that when we meet them, when they come into the realm of our Integrated Care for Kids project, mom and dad have gotten divorced. John is a veteran. He has PTSD that has not been effectively managed, and has just not been able to hold things together and is currently homeless. And as a result of losing that income from dad, since he's no longer in the military and not working regularly now, Sarah and the kids have packed up and moved in with her mother, Ruth, into her mother's subsidized apartment, which is a little too small for all of them, but they're making do. And are trying to adjust to living in a new town and a new life. And that is going particularly poorly in an obvious way for both Jameson and Sarah. Jameson is having a lot of challenges, and his school performance is certainly starting to suffer. He's not making good social connections in his new school. And so Jameson is the kind of child that might come to our attention because the school brings him to our attention. We've got this kid, he moved here 4 months ago, and just really doesn't seem to be doing well. Can we get him screened? Can we get him into your program? Well, part of the reason Jameson is struggling is that mom has been struggling, and mom has, for many years had been a user of opioid medications that she was, originally prescribed. But unfortunately, like many people, she has become opioid dependent, is not able to get herself off of the use of those opioids, and has now landed herself briefly in jail and then in treatment because she totals her car driving under the influence with the kids in the car. And so now she's off in treatment away from her children, and the children and grandma are trying to make do of what's happening. Jameson, unfortunately, along the way has realized he could try some of mom's pills. It's not something he's necessarily doing all the time, but he has gotten access to them and some other substances from kids in the neighborhood. And so that's part of why his school performance is not going so well. So we have 2 family members very, very much in distress. And then we have the younger child, Madison, who we don't maybe know as much about because she's 3 and she's not telling us her story. But she's got she's a wheezer, she's got some other issues like that. And so she too could come to our attention, either linked through Jameson or independently, perhaps through a daycare provider, or because grandma takes her in to get a well child check with their assigned Medicaid provider. And so at that time, she would undergo a screening, not only of her development, but also of her adverse childhood experiences and her social determinants of health. And based upon the sort of composite score of that, plus a score based upon her medical diagnoses and use of the healthcare system, that could land her in the INC project as well. And so because she's a wheezer and she's been brought to the emergency room a number of times, she's flagged as a high utilizer with wheezing. And then of course, due to mom's situation, she's scoring pretty poor, mom and dad's situation, she's scoring very poorly in terms of her adverse childhood experiences. So this is the kind of family that is the bread and butter of the kind of work that we do. So that just kind of helps us to have something to hang our hat on, and gives us a sense of the different systems that each one of these kids is interacting with, which is exactly what Brian is going to be walking you through today as sort of step one of how do these systems work together to try to give this family comprehensive care. Next slide. So the domains that we are required to work with are listed here. So we obviously start with Medicaid and healthcare, including behavioral health and sort of emergency behavioral health services, child welfare and other children's services, Title V services, education, specifically including both early education as well as the K through 12 system, anything interacting with the Individuals for Disability Education Act as well, certainly flagged as being particularly important. The food and the housing sector, and we're required to track food and housing insecurity for these children. And then we are highly encouraged to work with the justice system as well. Next slide.
Oh, you know what I would say, just to jump in for a second. One of the reasons, and I think you spoke to this, Christine, is that part of the reason for obviously the scenario in the case study is to really reflect this conceptual model of the pinwheel here, right? We're looking at the family, the individual, the community, and how these systems affect it. But in general, that's a conceptual conceptual approach. Here, we're actually grounding the work to say, here is a family that is interacting with these particular systems. And so that's something that I think is important as we go through the work here today, linking the scenario, the personas, the individual personas, right, to the actual use case that we can then go utilize to build out the solutions. And so that sort of process is something that is really important to sort of to actually explicitly state. Why are we using this? Why are we using this kind of the scenario approach? And hopefully that idea is very clear, or becomes very clear, in terms of the granularity that we need to get to, embedded in a family that's embedded in a system, right? So Christine, I don't know if you have any other comments on that, but that whole process is also helpful, I think, in engaging other people who are working on this to see how the dots connect and how the pieces go together.
Absolutely. I mean, there's no possible way that the healthcare system working alone is going to really change the trajectory of this family. But that's essentially what we're asked to do right now, is to try to, I mean, each sector, you know, whether you're child protective services, whether you're healthcare, whether you're the schools, you know, you sort of feel that the weight of the world is on your shoulders, and that you need to try to, if not solve each one of these child's problems, to sort of uniquely come up with a system and make all the calls and make all the connections that are needed for these kids and these families. And it's just exhausting and overwhelming and very, very inefficient. And so, you know, really the work that will transform this is to make it the norm that these sectors work together, and to bring that efficiency of communication between the systems. So that's really what we're excited to move forward with today in terms of demonstrating that this can be done.
Let me pause a second and just see if there's any, we've got a little time here, if there's any questions or comments that folks either put in the chat or raise your hand or just unmute yourself and bring out. Is anything jump into people's mind at this moment before we dive into the technical components of this?
Christine, is dental in there anywhere?
It's part of the sort of medical care, but you know, it's interesting that, like, we're also asked to measure and report on kindergarten readiness, and dental is explicitly sort of one of the sort of subdomains that is included in that. And so while we don't have, we do have some very sort of typical NQF clinical measures that we also are measuring. None of them are dental, but it's coming in our project into the kindergarten readiness component, that these kids are plugged in and getting the both the preventive as well as the dental treatment services that they need.
Thanks.
I have a question, Christine, which is that, could you talk a little bit more about the legal piece of it? Is the legal intervention or involvement limited to the criminal side?
No, it's actually civil is what is most recommended. But it's certainly not limited to the criminal side. But what's interesting is that this final outcome measure of children placed outside the home has not yet been defined. There's a inevitable Beltway Bandit contractor working on defining that outcome measure, and so we're waiting for it. And so I guess we'll have once that is developed and in front of us, we'll have a little bit better sense of exactly how that drives the project from the criminal standpoint. And so our personal approach right now has been more around the sort of medical legal partnership aspect, things like, how do we improve the environment that these kids live in, or make sure that they're getting the services that they need by obtaining legal assistance in doing that. We haven't, in our particular project, we have not yet made super strong connections to the juvenile justice sector, but that's certainly, coming.
While you also others think about that, I just want to make one comment, just tie this back again to the national action agenda. So, what Christine explained were, obviously interventions in each of these pie pieces within the pinwheel here. And we have organized the action agenda. There's about 100 people involved with it into these various groups. In various ways, in using social determinants as a way to study these things, and then to look at this particular set of issues and problems through that lens, through a legal lens, through whether or not it's predominantly through a civil legal lens, through a healthcare lens, through education, through housing. So we're trying to bring together people and subject matter experts, and it's an amazing group of folks who are participating, and you can actually follow along on the hub, or you get excited to participate, let us know. There's always room to bring in other folks to contribute to these set of recommendations. And the idea is to really get specific about what could actually help not only address what Christine and her team is trying to do, which is to help provide better services and supports to this family, and also how would you prevent that? What are the action steps that you could prevent that? So if you had an interaction with civil court around evictions or bankruptcy or children's issues, would that send off signals? Would that send off some information for the caseworkers who are dealing with one of the children to be able to start to connect the dots? And that's the big vision of how do we connect the dots and go upstream in a very specific way. And so let me just take one more question before we move on. James, I don't know if you want to, you're just sharing that, or if you had a question or statement you wanted to share along with what you guys did over there in Wyoming.
Sure. So my name is Jim Bush. I am Wyoming's Medicaid Medical Director. And we had identified the same problem that Dr. McCloy just clearly laid out for us. And so we actually developed an algorithm looking at what we called our super utilizers, the frequent flyers in the emergency rooms. And we, through intensive case management, even in-person case management at it for several years, we were not able to see any significant difference, except in certain cases when we found we could address the social determinants of health. And we had identified that really you need housing. And we also worked with corrections, and our frequent flyers were their frequent flyers, were the ones in the emergency room all the time, were showing up in the homeless shelters. And we're also showing up in our community mental health centers. So we knew that unless you could do that, and so we have actually proposed and written out a model around non-risk bearing regional care organizations, but we knew we had to have corrections, judicial, education, housing, human services, and behavioral health in there. And they had to have a way to share data. And so I'm just really excited that we came on what sounds like the same model. At least we're coming up with the same solution, which makes me very happy to hear. And we're actually hoping to do this in the next year or two.
Okay.
So,
Perfect. We would love to learn along with you, and I'm sure this learning team would be excited to track the progress and sort of interoperate as we go forward here. That's exactly the purpose, is to try to identify different initiatives across the country that are doing this and see what we can either contribute to them or what they can contribute back, given the tremendous need out there, the limited resources, and the urgency of time. So thank you for offering that, James. And
yes, I would really like to learn more and be part of this, and so we can share our learning together.
That's great. Michael and others will put in some of the links on the chat to the NAA and the hub. So if you haven't found that yet, it'll be easy to connect to it. So with that, I want to turn this over to Brian Hanspicker, who is one of our subject matter experts and is helping lead the charge on the proof of concept. Comes to the group with a lot of experience working in New York State on very similar and related ideas, a lifetime of experience working in technology and applying it, particularly to children's issues and many other areas, and has been helping, along with others for sure, really help sort of craft this message around Project Unify, as well as helping us move into implementation phase. So Brian, you're there, say hello. I'll drive your slides.
I am. Hello. Indeed, the Project Unify vision is to demonstrate how we can have replicable, standards-based interoperability between many different information domains, and try to identify where the intersections of interoperability might be that we need to solve, and what issues and challenges might come up where we can provide best practices, or in essence, a blueprint for how to get interoperability between these various silos. Next slide. So we actually have a core team of very diverse, experienced, knowledgeable subject matter experts working collaboratively together. They're both technical subject matter experts in interoperability, integration, data architecture, service-oriented architecture, but also, as important, we have information domain subject matter experts across healthcare, behavioral health, child welfare, adult social services, education, housing, nutrition, public health, and public safety. And it is an evolving team of people, and true experts in every sense of that word. Next slide. And their work is being driven by this set of user stories based around the Thompsons. Though our goal is to reach the point of satisfying the very complex requirements of the Integrated Care for Kids program, the user stories that we have created are multiple and are defined to kind of explore the different issues and challenges associated with interoperability that we're likely to find, trying to break through the barriers between these silos. So, for instance, the demonstration we're going to be doing today is around homeless social determinants of health information for John Thompson. Next month, single parent SDOH for addressing the needs of Sarah and the kids. In January, we may do a demo of homeless COVID, what to do with John if he comes down with COVID while he's in a homeless shelter. And ultimately, based on what the different solutions that we are able to put in place, start working in early 2021 on demonstrating the different aspects of user stories associated with Jameson and the integrated care for kids issues. How do we handle a mandated report for substance abuse, for instance, from an educational institution to child welfare? How do we integrate child welfare in with the court system so that they can submit a service plan regarding Jameson? Ultimately, how do we define health care plans across child welfare, healthcare, and behavioral healthcare in order to address Jameson's substance abuse challenges? Next slide. Each one of those user stories kind of picks at a thread associated with which different kind of record, which different record type do we need to exchange between which domains in order to enable a 360-degree view of the individuals or the family involved here, so that we can address the whole problem that this family and its individuals are dealing with, not just a specific siloed information domain at a time view. Next slide. So Project Unify, based on the vision, the user stories, and the associated understanding of what kind of data we need to be able to exchange between these different information domains, is to demonstrate the exchange of that data, understanding what governance challenges we may have. This is one of the things that Dr. McCoy mentioned earlier, that it's not sufficient to simply have a technical understanding of how we might exchange information between domains. We also have to overcome the bureaucratic policy and legal issues, statute issues associated with exchanging information. And do so based on what may be, in fact, domain-specific standard protocols for information exchange. And when we're exchanging information between information domains, it's also critically important that we have in place some common definitions for identity matching or person matching, what in the healthcare world would be called patient matching, what in the social services world is client matching. Is the John Thompson, for instance, that we're going to be sharing information about today, the same John Thompson in the homeless management information system as is in the social service workers system, as is in the electronic health records system that his doctor may end up using. So we need to be able to come up with best practices for person matching across all of these different domains, and do so based on some standard tools and best practices. In order to make that happen, we need to define some cross-domain data maps. What information about John Thompson in the homeless management information system maps to what information in the social services case management system, and what of that maps into the healthcare system, so that we can compare and exchange apples to apples between these systems, and have associated sort of reusable APIs or interfaces for being able to share this information, and do so based on common security practices, common security protocols and technologies. All of this we are going to be documenting in a repository of best practices and specifications, in essence, a set of blueprints for how to do this, both across different jurisdictions, across different vendors' solutions, as well as ensuring that this is something that is replicable across new information domains that folks decide in the future need to be added in and incorporated into providing that 360 view of individuals, families, and households. Next slide. So we have specific core technical working groups on this, such as person matching, a security working group, privacy and confidentiality working groups. We have folks that are working on standing up fire servers and common human services platform. We're working with the Michigan Health Information Network and their interoperability land as a testing environment and gaining their invaluable help in understanding some interoperability issues that they've already addressed within their testing environment, and are working at standards harmonization and a better understanding of how they interrelate between HL7's FIRE, the National Information Exchange Model, the Common Educational Data Standards, and others. As well as we've got a group working on defining best practices around user experience and user interface mechanisms and technology. And finally, perhaps most important, we have folks working on governance and equity, understanding what information is necessary, but also what information should we be providing extra protection on to ensure that we're not sharing inappropriate information or information that could do harm rather than good for these individuals, families, and households. Next slide.
Brian, before we jump to the
And
next,
yes.
I just wanted to just reiterate that in an important, just for make sure it's crystal clear, is that the work that's going on in these work groups is made up of the volunteers and the participants in the NIC and other folks who've come to participate as partners. And that these kind of artifacts, what's exciting about this is that as we look at the integrated care for kids sites and other jurisdictions at the county or at the metro level or even the state level, are all grappling with these things. There's a number of federal initiatives under the Accelerator program, the Gravity Project, the Da Vinci program, the FAST program. At the federal level, the Office of National Coordinator, that are also helping sort of define that. So we want to make sure that we are making particularly the social, human services, legal, educational needs and requirements known, right? And so that we're presenting these things, as Brian said, in a kind of a blueprint, a roadmap, so others can pick them up and use them. So you're not starting from a blank page, right? The whole idea is to accelerate this effort. And there's some fundamental things that organizations across the country are always faced with, not the least of which is data standardization, harmonization, privacy, and confidentiality. So that's part of the underlying purpose of this, is to make those things available and to create that in many ways, that that collaboration that's helping identify these things, push them out so people can start farther along in the process. So thank you, Brian. I don't know if you wanted to.
Next slide, I was going to say, Daniel, you're a great straight man, because I was going to mention that as part of the blueprints that we need to write, we are digging down into the gory details associated with these various working groups. And I'm not going to try to read this entire slide off. There had been a joke that we should make it a challenge for the group to read off one bullet at a time piece, but we won't do that either. Let's just use this as the message for this slide, is that we have experts that are diving down deep into the gory details of these particular areas, to better understand what is going to work, what isn't going to work, and document them as part of these best practices blueprints. And that those in turn are informing things like the demonstration you're going to see each of the next 5 or 6 months. The demonstrations do not, at the moment at least, implement everything that we're looking at here. We're picking off different aspects of Project Unify and exploring what are the issues and challenges so that we really can put together a credible and replicable set of these blueprints for other folks to then take and use to implement solutions, for instance, for the 8 different integrated care for kids programs across the country. Next slide. So today's demonstration is going to focus specifically on the challenge, some of the challenges that John has. He's currently homeless in New York City. He's underemployed. He's under the poverty level. He just doesn't make enough money to support himself, let alone to be able to pay his required child support, which is causing problems for Sarah and his kids. He's also unable to afford rent or nutritious food. So his challenges are he needs food assistance, he needs housing assistance, he probably needs training for a better job. But he doesn't fully understand how to navigate the system to get all of the services that he probably is eligible for through all of the different kinds of agencies that are available and out there in New York City. And it's pretty amazing how many are available in New York City alone. And he's also bedeviled by the fact that there's fairly poor communication between the various agencies that might be able to help him. Partially because of the siloed mindset, but also because we just haven't addressed the question of interoperability between all of these various systems, many of which have been implemented with very old legacy systems, and which are probably not going to be replaced anytime soon. So how do we break through these barriers between the various agencies? Next slide. So for this particular demonstration, what we're doing is talking about at least the first 2 different kinds of records or pieces of information that need to be able to be exchanged on behalf of John Thompson. The first is he's checking into homeless shelters on a regular basis. The homeless shelters have a fairly good picture of John. They've got a lot of demographic information for him. They've got, they may have income information on him. They may have disability information on him that is missing from the social services system. So the first challenge is, can we, as part of recognizing that John Thompson is chronically homeless, ensure that the social services information can share information with the homeless management information system in the city, so that the social workers in the city can help John get the services and benefits that he qualifies for and that he needs in order to live a better life. And assuming that the social services caseworker can get a hold of some information about John and let it bootstrap their work in getting assistance for John, can we readily get a rental assistance form from the local social services agency over to a housing agency that can actually put that referral into action? So that is the setup description of what's about to happen for John Thompson. And now I think I get to turn the presentation over to Eric Yan of Serving Link, They implement HSLink, and Matt Bishop, who's the CEO of Open City Labs and their Navigator product. You're on, gentlemen.
Hi, everyone. I'm Eric Yan with HS Link. And if you could advance one more slide, please, everyone. Thank you. I'm going to show you the schematic of what this demonstration involves so you can kind of understand what's going on before we show it to you. Front and center, at least not spatially, but in a priority sense, is John Thompson on the right. This is our homeless services client, part of our use case. And in the middle, you'll see HS Link, which is what you might call a community data exchange, serves up data in a data-centric model to these other apps that may use HS Link for their data needs entirely or partially. We have a homeless management information system example app called Pitone. And that gets all of its data from HS Link. And Open City Labs on the left of the diagram is resource match and eligibility screening app, amongst other things, the Navigator app. And it uses HS Link's data to do client processing, but it also has its own data that it adds to the mix. So likewise, legacy systems could be involved in this as well. And then the other icon on the screen are the agency applications. That's the end product that will go out on behalf of John Thompson. So forgetting about the numbers now, let's just step through each sequence of this in turn so I can explain what's going to happen in the demo. So before this demo even starts, the social service agency, Core Services Group, I think it's called, it is a fictitious agency running Open City Labs Navigator app, and they're going to subscribe for changes to social determinants of health, maybe some particularly important Department of Housing and Urban Development, homeless management information systems elements from the data-centric warehouse. So if anything changes in the data set in HS Link, that Open City Labs Navigator app run by Core Services Group will be notified of those changes. Next slide, please. So for the data to change, we need to collect information from John Thompson about his current situation as he either enrolls or gets an update and an enrollment in the Homeless Management Information System app. And then that will send data immediately in real time to HS Link. And then the notifications will, in step 3, push over back to Open City Labs. These are fire push notifications. These aren't ones we made up. These are from HL7 specification. And the same APIs will also be used in the December demo. So we're using standard specifications for listening for changes to data in real time. Okay, so next slide, please. And the final step is that Open City Labs doesn't just sit on the data. They figure out what services John Thompson is available for on behalf of the Core Services Agency, and auto-completes applications on behalf of John Thompson, perhaps automatically submitting them. But that's the idea. Seamless interoperability. John doesn't have to reapply for things. The data that's in the HMIS gets into the application if he consents. And that's what we're going to show you. So let's move on with the demo now. I'm going to share my screen. Can everybody see my screen? Anybody say yes? Okay. Yep. Great. So we're logging in to an HMIS. And so then we're going to use an OAuth authentication. You probably see this when you log into anything on the web. You know, your account. This is a caseworker's account in HS Link.
We can't see the browser. Is that what you're showing us?
Yes, I'm showing you the browser. Oops, I didn't answer a key question to Zoom. Are you guys, can you see it now? Okay.
Yeah,
Thank you.
I can see it. Yeah.
what I have a team for. Thank you. The rest of you would have just let me rattle on. Yeah, we're done. Okay.
Apparently it takes a village.
Yes. Okay. Sometimes even more. So this is a caseworker at the HMIS account. This could be used across apps, but it gets the data out of HS Link. So kind of like your Google username and password to authenticate to Zoom or something like that. It's OAuth. It's what the 21st Century Cures Act recommended OAuth 2, and it's what Smart on Fire, if you're interested in acronyms, also uses. So we hope to be portable with all this with healthcare standards. We log in. Now, pretend we're a fictitious caseworker doing an intake on John Thompson. He walks into the emergency shelter in New York City. They collect some personal identifying information on him, and they find his record. And they look at an old enrollment that already exists for John. And you can see that he currently isn't designated as chronically homeless. There's it's a calculated field. You can't just set it directly. Let's look at the rest of his record. This is like a database view of his enrollment, not something a caseworker would really use. But I just want to use this to demonstrate that he's currently doesn't have a physical or a disability of any type, and not set as chronically homeless. And this is a social determinants of health housing instability screener field set up by the people volunteering on the Gravity work group, setting those for HUD HMIS. And right now, the value is not the one that we are looking for. We are looking for if he's living in a place if he was previously, on enrollment, living in a place not meant for human habitation. So what I'm going to do is, for this demonstration, is I'm in an app. Matt is in the OCL app. He's running that, and he'll show you that. I'm going to change some things in Petone, and you're going to see them change in Open City Labs Navigator app. So real-time push notifications using PubSub. So Matt's app has subscribed to hear about changes in the living situation and changes in chronic homelessness. So I'm going to now, in the background, I'm going to hand over the screen share to Matt. He's going to show you Open City Labs Navigator app for the fictitious social services agency in New York City called Core Services. And in the background, I'm going to change the data elements, and you're going to see the push notifications come in his system. So I'm stopping my share, and Matt, you may take control.
All right. Okay. Can people see my screen?
Yes.
Great. Okay, so here we have Laura Shoemaker. She's a case manager or a care manager, and we can see all of her clients. Now, Eric, if you could just tell me when you've made the changes, and I will refresh my screen.
Okay, I have not done it yet. I am now editing them. We wanted to do it this way so that you'd see the real timiness of it, if that's a word.
Great. So we can see the applications for government programs and referrals and what the status of these referrals are. We can look at outgoing and incoming referrals.
I sent it, Matt.
When have you done it?
Yep, I sent it, Matt.
Great.
So within an amount of time, if the demo works the way we want it to, you'll get notifications.
Here it is. We have, let's move this. There we go. So here's the notification, and we can see the changes that Eric has made here in John Thompson's journey. Client is chronically homeless. Client's living situation is place not meant for habitation. So if Laura wants to help John access some programs or services, we'll start with goal setting. So she's going to set a goal. Access rental subsidy. And this barrier section, this could be kind of populated by standardized social determinants of health assessments like PREPARE or accountable health communities. And so that's the barriers. You can't afford the rent. We're going to set a timeline for when we are hoping to achieve this goal. And now, one of the programs that we know that we have 300 government programs across 30 agencies, but one of the programs that we want to learn more about that might be able to help John is this core services group program. We can see where it's located. We can share this particular program, text it to John if we wanted to do that. But we're going to decide we're going to go back and we're going to screen for eligibility for this program. So we're asked a series of questions. The case manager would just be interviewing John here. And then based on the entries provided, we've determined that John is actually eligible for this program. So we're going to go ahead and apply for the program. So here what's happening on the back end is we've developed a solution that can take a PDF and then without coding, turn it into a website, a web form essentially. And so what you're seeing right now is it's kind of processing that and it's simulating, essentially auto-populating the data from both OpenCity Labs and ServingLink. And one of the unique parts about this solution is that even though if we're not integrated with 30 different government agencies, if the agency accepts PDF application forms, we can provide the automation by autofilling this for providers, so you don't have the kind of double duplicate data entry that is so common, unfortunately, in the social services world. Here we can essentially then auto fax it directly from the screen. We can download the form if it needs to be locked in, and we've essentially autofilled that PDF. So that's the demo we have for today, and I look forward to showing more next month.
Thanks, Matt.
When do we applaud?
I think now
Nice
is
work,
time
guys.
to applaud.
Nice work.
We have just one more slide left. So now would be a good time for discussion. The final slide is just our roadmap of upcoming demos.
So one question I have, I just want to make clear here is, you showed one very particular exchange of information on an automated basis. It's important, Eric, if you can speak to this, that, HS Link, the whole idea here is that there is a constellation of services that can be automatically shared on a subscription and on a basis like that. So you may want to talk a little bit more about that. These kind of conversations are sometimes, we have a range of people who are technically knowledgeable. So diving a little more into that might be useful as we talk about pub sub and some of those pieces for people who may not want to raise their hands, raise a question and or raise their hand and ask a question. Might stimulate some thinking about how this could be applied elsewhere as well. And that this is just really step one, which is important.
Yeah, definitely. I mean, that's the vision is it's not one vendor. It's a way to move data between vendors using standards. Human services sort of either mimicking or just using things that healthcare has, depending on if it fits or not, or if you're trying to talk to a healthcare, a clinical system. But that's the idea. This isn't one company. This can be in a number of companies. And yeah, we showed HS Link, but there could be other data warehouses in there. So the key thing is, I said it, and I don't know if I really define it, but data centric is the thing. The data is sitting in a place where it can be accessed by any number of apps. That's the key thing going on here. And those data centric systems are powered by, are serving up data that follows an ontology. So it's not just, we made up our data. It's following some specification that some standards group came up with, or maybe just something that, it's accepted because so many people use it. So that's really what's driving the interoperability is, systems that can talk to many vendors. And then, yes, I saw one comment, consent is something that also has to be shared. And we didn't really show that in the demo, but consent can be collected, at any step of the game, depending on what's happening at which point. But that app I showed you, the HMIS app has a consent, and it what would have happened if we didn't have consent turned on for John Thompson, it wouldn't have published the notifications out to Matt's system, even though they had subscribed to hear them. So there's a lot of nuances and much more standardization has to happen. But what we've got now works and can move the messages across. And we hope to work more with the healthcare people to really make this a seamless system.
And I would add in that as we move forward with some of the recommendations that are coming out of the Privacy and Confidentiality Working Group, that we will be experimenting, let's put it that way, with the idea of using the consent to share mechanism for human services information, in addition to using it for gaining real-time consent for sharing healthcare information. So that's on our roadmap, if you will.
Guys, this is really impressive. Thank you. Question, it's related to the question James Bush just asked online, which is, as we have a collaborative in a community, there are some who are more equal than others. There's some full-time agency participants in the system. There's some volunteer groups there, and they have different roles. They have different roles and different rights. And we're sitting around kind of agreeing on that. So we're setting up a set of business rules as to who's allowed to see what information. Is there a kind of a shared registry of business rules as opposed to a binary, you have permission, you don't have permission?
Well, regarding data governance and data sharing, is that what you're asking about in terms of business rules? Is that what you mean by business rules?
Yes. Who's allowed to see what data? So for example, there's some agencies with some sort of an agreement, like I could have a business BAA with a social service agency, and then there's an NGO that's kind of in the same field, and they would have different rights to share.
So
based and policy-driven authorization is
yes, Eric's serving link has consent-based APIs built into it, and then as Brian mentioned, and I believe in a January demo, Brian, correct me if I'm wrong, in terms of the schedule, was it January or February that we were going to be demoing consent to share, or am I getting things?
I hope we'll all be there by then. Yes.
So
what I'm talking about is differential consent to share.
Can you say more about that, David?
If there's a set of data that in the data warehouse, there's all this information about me. Mm-hmm. Some of it is okay to share with everybody in the collaborative. Sure. Some of it is not. Some of it can only be shared with certain groups. And some of it can only be shared under certain circumstances. In other words, there's a set of business rules that will some will be national, some will be local, some will be agencies will say, well, I'll participate, but only if you protect the data in this way. And I'm just wondering whether in somebody's roadmap, there's a thought of a business rule registry, if you will, that would record who has what rights to do what.
I know
it's certainly in my roadmap, whether or not it's in the roadmap of the vendors involved.
And also, David, I believe I'm answering your question. You know, there is consent to share that is one, you know, similar kind of registry that we'd like to look at. But then there's within HS Link already, and I think a lot of different human services software support this. They have fine-grained consent sharing rules, and so you have your default rules, and then the client can accept or reject those. And then and we also have project groups, groupings of agencies that can be shared to, or subsets of them. So within systems, you can share information that way. But the problem is, you know, the HS Link consent APIs work for any system on that same data store, right? But how about between two different vendors? So you know, a consent API with rules, something like consent to share, or that used for human services, with those groups defined, and you can register for them, and the consent recorded, stored centrally. That's probably where we need to go overall over time.
Yes.
Sounds right. Yeah.
And I also wanted to respond to a question by James Bush about health information exchanges and other data governance issues. So we are partnering with health information exchanges. There's one in New York that we can't quite announce the name yet, but they're a big one, and different states, as mentioned, have different laws around consent. So in New York, you can either provide, via the health information exchange, you can either provide, you know, provider-centric consent. So yes, all of my data can be sent to Mount Sinai, or you can provide community-wide consent, which means anybody who's providing care to me can access my data via the health information exchange. So this is something that needs to be configured based on the rules of that state, because the states have different laws and rules around regulatories, around sharing data, and around health information exchange data sharing.
I might also add that you know, the relationships as described earlier, we didn't go through all of the relationships that are involved with the development here, is the Michigan Health Information Exchange and the Interoperability Institute, which is in many ways trying to simulate that work between healthcare providers and HIEs. They run, MyHIN runs the Michigan Health Information Exchange. So we're very aware both of the opportunity and the interest by the Office of National Coordinator to look at the HIEs as a mechanism for actual, you know, sort of the roadway, the transportation over the HIEs of secure information, in addition to healthcare, some of these other ways. Excuse me. So we're very, very sort of focused on what are the ways that information can be shared, through what existing mechanisms. Are there existing standards that can be brought to bear, not only from the data sharing, but from confidentiality and privacy, from all those kinds of things as well, to, again, to look at what is out there, what's working, what successes have people had, and how to bring that on. So over time, we'll be bringing more of those examples in, and being able to sort of simulate that through some synthetic data, and then ideally be, you know, sort of crafting this to the specific needs of New Jersey and Dr. McCoy and other jurisdictions who have stepped forward and have expressed interest in working from the blueprints as they're looking at their interoperability plans. How do you go do this? Again, to learn from this group of people thinking about all of these problems that everybody has to deal with all the time. So so let's keep going. We got a little more time to entertain questions and comments, and I actually asked Bill Kowalski if he would say a little bit about consent to share and his experience with that. So Bill, if you're there, you might want to say a bit about that and how we're looking at that as a model as well.
Yeah, just a few things on I noticed somebody asked about the 42 Part 2 data and consent to share, and we developed for SAMHSA a consent to share for that 42 Part 2 that exists, and it's all digital, and it's being used in various states around the country, in Minnesota in a particular county, and the HIEs are starting to adopt it. And to me, that can easily be adapted for human services, social services, because you know the most strict is the 42 Part 2. And so if you can do it for that, I mean, I envision that you can do it for individuals that are receiving human services. And I envision this as, you know, the individual owns the data. And so if they go through this consent to share and say agency A can see this, agency B cannot see the information, and it gets down very granular to what particular service even. So the technology exists out there and it's being used today.
Do you think there are potential applications for other sectors? I'm just thinking about as fearsome as 42 is on the education side, the FERPA police will claim that that's, even though it's not supposed to be, a significant hurdle. Are there ways that do you think can be extended out, or models like that can be extended out to really facilitate the that opportunity to opt in or opt out of things like that?
I think you can, but you brought up in my career in doing interoperability, the most difficult was Department of Education.
Right.
So even though you may have the technology and have that, to get them to agree, maybe something else.
Daniel, this may be one of those situations where we may not be able to get the Department of Education to agree in general to using, for instance, consent to share for exchanging educational records, but we may be able to get it applied to a specific one of those points of interoperability, like the submission of a mandated report between a school information system and a child welfare system. So I'm suggesting that we can kind of pick away at this a little at a time.
Yeah, and I think that's the underlying point here. Is it is not we're not showing a comprehensive system for interoperability across all domains, systems, levels. It is a incremental process that is being sort of methodically worked on now that things are moving forward, and sort of step by step doing it, but doing it in a way that is implementable. And I think that's one of the really exciting parts, is to be doing it not just in a test bed, but in a place where that can really inform the requirements development and inform the implementation opportunities there.
And implementable in the near term. We don't have to wait 5 years, 10 years for a standards body to get around to defining the overarching umbrella of standards for doing this. We're just picking and choosing existing standards that have already been agreed to within different information domains and saying, you know, that one's pretty good. We ought to just make use of it.
Have you guys given some thought to governance and ownership in the following sense, that there's some very interesting proprietary apps that you're linking together, and there are lots of them in the marketplace, and there'll be lots more. In order to make them really work well doing what you're doing here, would it be useful to have some things in commons services in addition to common standards? And if so, what would those commons things be?
Well, that's in fact exactly what we are exploring. That is what we're trying to feel our way around to defining. What are those common standards? What are those common services? And what are the common data mappings that we need to do in order to enable those common services to be shared between multiple different information domains? So, for example, I could imagine if we're doing referrals, that the fire referral resource might be something we could share between healthcare, behavioral health, human services, maybe even the educational world. If a guidance counselor needs to be able to make a referral for one of their students to, for instance, child welfare, is that a mechanism that they could make use of? But in order to do that, we now need to have some common some information in common between those different systems. We need to understand that, for instance, a healthcare patient is the same as, roughly the same as a human services client, which is roughly the same as an educational student. And what are
Right,
the
but
specific
Brian,
elements that we need to map between?
but those are the arguments for having standards, and I all for that. I'm asking a different question, which is, are there ongoing software as a service applications, services that you can imagine would be offered on like a not-for-profit basis for the community that by subscription that just offered in common to make things work?
Well, actually, a lot of what we're doing is built on top of open source products. Like HS Link is an open source human services framework. And my understanding is that HS Link is incorporating something called OpenCR as a person matching mechanism, which is an open source based. I think it's called client registry, but it's the equivalent of a patient matching mechanism specific to human services clients. So the answer is yes. Do we know what they all are at the moment? No. Could we try to define some more along the way? Absolutely. You got any recommendations?
That's a great segue, Brian and David. We're at the 1:30, and hour and a half has rushed by, and I think that is exactly the place where that's so exciting about this effort, which is we're really trying to bring in and bring together sort of thinkers and doers and planners and folks who care about this from whatever particular vantage point, from a legal perspective, a technical perspective, a standards perspective, all those kinds of things, so that we build this out so we don't continually have to reinvent the wheel over and over again and then go implement that. And so the implementation part is what's really exciting. That ties back to the National Action Agenda, ties back to New Jersey and the Inc. sites, and a number of other sites that are planning on, are working towards this initiative. And so let me just invite you to participate in this work and join. As I said, Michael's been putting out the links to the hub. There's a member opportunity to become a member, and you can certainly reach out to us directly if you have interest in this and want to participate and join the effort. This slide, the slide deck will be made available very quickly. So that, look for it on the site in the next day or so, or probably by Monday, I would guess, along with the video. There's a lot of material on the site right now from each of the work groups and from the NAA in general. So we're interested in your participation. Thank you for joining us today. And with that, I want to again thank everyone for presenting and participating. And I wish all of us a safe and a reasonable weekend where we can enjoy our life and our freedoms. So with that, be well. Thanks, everybody.
Thanks, everybody.
And we'll look forward to talking to you real soon then. Thanks. Bye-bye.
Bye.
Bye-bye.
Take care all.
Thanks, everyone. Bye.
Bye.